இது இப்போ வீடியோ போயிடுச்சோ?
வீடியோ போயிடுச்சு. ஆமா,
வீடியோ போயிடுச்சு. இப்போ வீடியோ வருது இல்லையா?
ஆமா ஆமா. பர்ஃபெக்டா அது வருது போட்டோட.
பர்ஃபெக்டா வருது. ஓகே ஓகே மேடம். ரைட் மேடம். ஸ்டாப்.
Sir, good afternoon, sir. Lakshmi here, sir.
Hi, madam. Good afternoon, madam.
Sir, screen sharing and all working, no, sir?
பாத்துறோம் மேடம். எல்லாம் ஒர்க் பண்ணுது. நோ ப்ராப்ளம்.
Okay, super, sir. Subbu sir join பண்ணிட்டாங்களா?
சுபு சார் ஜாயின் பண்ணா.
அடியே இங்க தான் இருக்கேன்.
Oh, sir, good afternoon, sir.
We have gone live on YouTube, so.
Oh, all right. Okay.
It is getting recorded.
Okay, sir. Sure.
Yeah. So everything is working. Divya ma'am, you want to try and share your screen and see? Check. Divya Lakshmi ma'am.
Sir, Subbu sir.
Yes, sir.
The co-host ஆக்கிட்டீங்களா?
ஆக்கிட்டேனே சார். நீங்க already your co-host.
அப்படியா? Okay sir. Thanks.
Hello, good Divya Lakshmi ma'am. Good afternoon.
Hello sir. Good afternoon sir. So I'll just
yes ma'am, please.
have this share.
Yes.
Yeah, PowerPoint is visible, right?
Visible ma'am. Full screen ma'am.
Yeah.
Yes. Move பண்ணி பாருங்க.
Yes, ma'am.
Yes ma'am.
Moving,
All
ma'am.
fine. Super. All fine ma'am.
Yes, ma'am.
Thank you.
Thank you sir.
ஸ்பீக்கர் ஸ்லைட் போட்டு பாக்குறீங்களா இளையராஜா?
மேடம்
ஸ்பீக்கர் சிவி ஸ்லைடு போட்டு பாத்துட்டீங்களா? அது
ஸ்பீக்கர் ஸ்லைடா? சார் ஸ்பீக்கர்ஸ் இன்ட்ரோ ஸ்லைடு உங்ககிட்ட இருக்குல்ல சார்? சுபு சார்
இப்போ நீங்க அனுப்பிச்சது தானே சார்?
ஆமா அதேதான் சார்.
நான் போடணுமா? போட்டுறேனா?
போட்டுருங்க சார். உங்க கன்வீனியன்ஸ்க்கு அது போட்டுடலாம்.
சரி. நான் பாருங்க. Give me 2 minutes.
மேம் லக்ஷ்மி மேம், நீங்க ஃபர்ஸ்ட் ஒரு பிரீஃப் இது கொடுத்துட்டு சாரை இன்ட்ரோடியூஸ் பண்ணிட்டு
Sure, sir.
அப்புறம் அந்த இன்ட்ரோடக்ஷன் சார் பண்ணுவாங்கன்னு சொல்லிட்டு ஸ்பீக்கர் இன்ட்ரோடக்ஷன் முடிச்ச உடனே ஸ்ட்ரைட் we will be into the program.
Slide is seen?
சூப்பர் சார். ஸ்லைட்.
Yes, sir.
சார் அந்த ஸ்லைடே போடணும்னு நினைக்கிறேன். ஃபர்ஸ்ட் அந்த இனிஷியல் இருந்தது. இது
We have another 5 minutes more. I'll just go on a mute mode for a few minutes. Okay.
ஓகே.
Pongudi ma'am has joined. Hello ma'am.
Hi. Hello sir.
Hi ma'am.
ஆடிபிள் பூங்குடி.
Audible. Okay, that's fine.
உங்களுடைய மேம் கொஞ்சம் லவுடா இருக்கணும்.
Loud. இப்ப சார் ஓகேவா சார்?
ஆனா கிணத்துல இருந்து பேசுற மாதிரி இருக்கு.
மைக்ரோஃபோன் யூஸ் பண்ணணுமா? ஹெட்போன்?
பாருங்க மேம்.
Yes, ma'am. Yes, ma'am.
இது கொஞ்சம் கிணத்துல இருந்து பேசுற மாதிரி இருக்கு. You want to try sharing the slides and see once ma'am?
வரைக்கும் யூஸ் பண்ணதில்ல. ஓகேவா தான் இருக்கும். இல்ல if I speak loudly is it okay now?
Better. நீங்க ஸ்லைட் ஷேர் பண்ணி பாருங்க மேம் ஃபர்ஸ்ட். அது முடிச்சிடலாம்.
ஸ்லைட்ஸா? ஓகே சார். Okay, can you?
Yes ma'am. Full screen ma'am. Is it working? Full screen working? Yes.
Okay sir.
Yes ma'am.
Is it okay sir now?
Divya says okay.
Divya says okay, but நீங்க you say not.
Slide move ma'am, move பண்ணி பாருங்க ma'am. Slide move பண்ணி பாருங்க ma'am.
Slide move பண்ணா okay, but voice.
Yes, move ஆகுது ma'am எனக்கு.
Slide move ஆகுது, but voice is it clear?
கொஞ்சம் லோவா இருக்கு வாய்ஸ். But I can hear, but ஆனா
தெரியல. I can try. நான் பார்க்கறேன். இது
Ma'am, if you have headphones, நீங்க connect பண்ணிக்கோங்க ma'am.
okay. Hello.
Yes, ma'am.
பேசுங்க மேம்.
Sir, is it better, sir, if I use the headphone? இல்ல அப்படியே தான் இருக்கா? எனக்கு ஹெட்ஃபோன் வேலை செய்யல.
கொஞ்சம் இதுவா தான் இருக்கு மேம். கொஞ்சம் அந்த வாய்ஸ் அந்த லோவர் சைடுல தான் இருக்கு.
You come near the screen and speak, ma'am. It's okay, ma'am. Doesn't matter. Don't use the headphone if you're
ஆனா
not
we are
comfortable.
able to hear you.
Okay, but இப்ப ஹெட்ஃபோனா without headphone it's the same தான் இல்லையா?
It's the same, da. Yeah, I think you're still using the same microphone. You're not using the headphone or the microphone.
மேபி செட்டிங்ல இருக்கா சரி நான் சர்ச் பண்றேன். ஓகே.
பரவாயில்ல மேம், இப்படியே யூஸ் பண்ண மேம். ஃபோன் கம்ப்யூட்டர் கிட்ட வந்து பேசுறீங்க, அவ்வளவுதான் முடிஞ்சது.
It's working. இதுல கேக்குது. I can hear it. When I remove it.
கொஞ்சம் சத்தமா பேசுனீங்கன்னா ஓகே மேடம். பரவாயில்ல.
கொஞ்சம் சத்தமா பேசினா ஓகே. இருங்க ரிமூவ் பண்ணிட்டே பேசிக்கிறேன். That's what எனக்கு ஏதோ ஹெவியா இருக்கிற மாதிரி இருக்கு. இந்த செட்டப் ஏதாவது மாத்த முடியுமா? மேக்ஸிமம் வேல்யூல தான் இருக்கு. ஸோ ஓகே சார், நான் எப்படியே பேசிக்கிறேன். ஓகேவா? கொஞ்சம் லவுடா பேசிக்கிறேன் சார். தட் வில் பி மோர் பெட்டர்.
Lakshmi Prashant ma'am, we'll start. It's 2:45.
Yes, sir. Shall we start, sir?
Yes, please.
Yes, madam.
Good afternoon, everybody. On behalf of the IAP CCB, I deem it a great pleasure to welcome you all to this online CME on adolescent health. Now, this has been planned as a part of the Adolescent Week 2024. We are deeply grateful to Sri Ramachandra Medical College and Research Institute, the Department of Pediatrics, for coordinating this and putting this together. Of course, I'd like to also thank our IAP CCB President, Dr. Lakshmi ma'am. She's always supported the academic programs, and she is, the brain behind the most of it. Thanks to her too, and congratulations to her on becoming the director of ICH. I take this opportunity to congratulate her again. So today we have curated very excellent topics, very relevant to adolescent health. And as we all know, pediatrics is all about holistic care. So this time we are looking at adolescence as a period of transition, and we will be discussing mental and physical health issues, very, very relevant to this crucial phase. I'd like to request our secretary, Dr. Subramaniam sir, to take over, introduce the speakers, and give an overview of what we have planned today. Thank you so much. I'd also like to thank our EB member, Ilayaraja sir, for all his efforts in coordinating this program today. Thank you so much. Over to Subbu sir.
Thank you. Thank you, Lakshmi, for that wonderful introduction. As always, it's been a pleasure to be a part of any of the IAP-CCB event, and it gives me great, pleasure to be here as part of the Adolescent Week. Adolescent health is something that we all have to really put our mind into and start working towards, because that is something that is not focused on much in our medical school through our college time. So we have with us a galaxy of speakers who are well known and need no introduction from me, but nevertheless, as a part of my job, I will do this. Today we have with us Dr. Sarla, Professor of Pediatrics from SRMC, and ma'am has already been an active member in Adolescent Health Academy, and we're just waiting to hear from her, her perspectives on the same. With us is also Dr. Divya Lakshmi, pediatric endocrinologist, well-known speaker, conducts a lot of training programs for postgraduates and pediatricians. She's always a pleasure to hear. She's a star as far as these things are concerned. Thank you, Divya, for being with us today. Pungodi Bala ma'am. Ma'am is trained in UK in child psychiatry. Ma'am has been associated with me for quite some time, and I've seen ma'am work at the ground level also. So indeed, good to meet ma'am through these channels also again. Thanks, ma'am, for being here. It's indeed a pleasure to have you here and hear from you. And we have, of course, our own Dr. Ilayaraja, an associate professor of pediatric pulmonology at Ramchandra. He's also an EB member and of IAP-CCB, and he has been coordinating today's program. Thanks to you, sir. And it's indeed a very nice curated program that you have here. And thanks for organizing the whole program. I think I'll hand over the proceedings to the speakers directly so that we don't waste much more of our time. Over to Sarla, ma'am, I think.
Good afternoon, sir.
Good afternoon.
Good afternoon, everyone. It's my great pleasure to be part of this IAP, the program as a speaker today. And my topic, I'll just share the screen first. I'll make it full screen. Hope it's visible.
Yes, ma'am.
Adolescence. Actually, the topic is very to our heart, because this adolescent period is a very crucial period, as well as this is a transitional period between the childhood and the adulthood. We consider this age group as 10 to 19 years as per WHO. For convenience sake, we divide the age group into 3 phases, like early adolescence, mid and late adolescence. The normal adolescent development, if we take, it has lots of changes, especially the rapid changes which takes place in the biological, social, and psychological facets. The biological changes is mainly related to the gonadal maturation, and the cognitive skills and the emotional maturity and the self-identity, which gets matured from the early adolescence throughout the period of mid, and it gets matured by they reach late adolescence. Social development is a very important component in adolescent development because it's being influenced by the peer group as well as the family members and the school in which they study and the community in which they live. Coming to the brain growth, here the prefrontal cortex and the amygdala and the limbic system are immature in adolescence. And it's being the reason for their cognitive immaturity and impulsivity. As they grow, the maturation takes place from the occipital lobe to the frontal lobe, and the prefrontal cortex is the one finally gets matured, especially by the time they reach late adolescence. The physiology of adolescent stress. Here, the adolescent stress is a very important component because adolescent period itself, they feel like having some stressful period. Here, how to cope up with the stress, they need to know, especially if they know the physiology. Here, the thing is, there are greater level of cortisol level as a response to stress takes place, especially in this age group. And the adolescent brain is more responsive to glucocorticoids, and the negative feedback response to glucocorticoids is blunted, and it leads to the storm with heightened sensitivity to these stressors. Especially when we come to the adolescent health visit, it involves the access to the health care first. They need to have the proper health care system, and when they reach, they will be given the information in the form of psychosocial history, and we get the physical examination done with the problem identification and the intervention, and comes the follow-up. Obtaining information in the form of interview includes both adolescents and the parents. Here, the confidentiality and the privacy is the very key point to ensure that the information gathered helps the adolescent in a right way. And of course, when the intervention comes, the parents need to be, we need to get the informed consent from the parents, as well as the assent we need to get from the adolescents. The history taking from the pediatric part is adolescent part is little different from the pediatric thing, that we have the psychosocial history, which is no specific for this particular age group. The mnemonic is HATES approach we follow. Here it involves the home, education, eating behavior, activities, drugs, depression, sexual health, and the safety part we need to include in the history taking. Especially the home environment in which they live and the number of family members, how the relationship in the family, and we get the information related to the education like academic performance, how their peer groups and what is their ambition in life, and how their eating habits, especially when we come to these body image issues if they have, and the activities, how they spend their time, especially the media usage and the time they spend for the sleep, and what are the hobbies, are they playing in the daily way and doing exercise or activities. And other than that, the history related to some kind of mood changes, especially the depression part. If the behavior and the mood change is there for more than 2 weeks, the timely referral is very important, because it may lead on to suicidal ideation. Especially the history related to drug abuse, sexuality, and the safety part. 3 things are there. Here, the information related to the sexuality, like menstrual history or any kind of usage of contraception, or how they have the sexual abuse, or any such things like safety part, like violent acts or these abuse things and all. The information we can get only by gaining the faith of the adolescent in the form of maintaining the privacy and the confidentiality. We can get the information to help them in a right way. Follow-up of these adolescents is very, very crucial, because these follow-up visits only help them in reinforce the positive behavior, and it is mainly needed for every 3 months in case of well adolescents, and it may be very frequent in case of others. But only when we have the adolescent-friendly health approach, we have to follow, then they will get the faith in us and they come for follow-up. The common problems which are faced during this adolescent period, we can have the brief list of that. The most common we come across is the pubertal growth changes. because these biological changes, especially the changes in the body size and the shape, what they have with the growth spurt and the gonadal maturation with the secondary sexual characters, what they get, it can have an influence on their psychosocial health, because some may attain these growth early in their puberty, or it can be late. So they are called early and late bloomers. Both are actually comes under the normal physiological range, but still, since they have their when they compare themselves with the others in the peer group, they may get some kind of body image issues, and it can lead on to some kind of stress in them and low self-image like this. So what they need is a counseling part with the reassurance that it's a common normal phenomenon, and this is what the guidance what they need. If we come across children with adolescents with precocious puberty or delayed puberty, of course they need to be further investigated for the endocrine or chromosomal abnormalities and need the proper intervention. Coming to the common health problems, what we see is especially the nutritional disorders in the form of anemia, especially in adolescent girls, and other vitamin deficiencies and micronutrient deficiencies, which are very common nowadays, especially because children and adolescents are prone for this, eating junk foods, and they get into these micronutrient deficiencies. And obesity is an epidemic now; it's happening in worldwide. And of course, our next speaker is going to talk about that. And of course, the mental health disorders also going to talk about by the Dr. Pungudi Pala here. And we have the other problems what we have is the infections, especially tuberculosis and sexually transmitted diseases and HIV are common in this age group. And the problems related to substance abuse is also there, which is in the tip of the iceberg, which need to be identified and treated. And adolescent obesity can lead to problems like asthma or sleep disorders and reflux and metabolic syndrome. And physical health, if we say, the mild problems, what they have, sometimes the acne problem, even that also they may think very in a big way, and they have body image issues because of that. So all these need to be addressed, like acne or asthma or other respiratory illnesses, and myopia, dysmenorrhea, gynecomastia, or orthopedic problems, especially they are prone for sports injuries and accidents. Coming to the problem, especially nowadays, is the stress in teens. The stress in teens is nowadays a very common thing, because they have both academic stress as well as emotional stress. What they have is the stress. Sometimes they can't say they have the stress, but the warning signs we can identify in them or in this following way. Like they can present like body pain, tiredness, headache, and irritability, or sometimes they cry often, sometimes they may feel hopeless, and they can have kind of anxiety and nervousness. They may not sleep also. Maybe they may not eat, and the eating habits may get changed, and the performance in the school also may get deteriorated because of that. We need to pick up these signs early, these warning signs, so that we can help them in an early way. And the poor school performance is a very common problem which we come across here, because here we need to identify the problem, what they have, underlying problems like change in school, or some kind of bullying in the school, or disruptive peer groups, or rarely some kind of poor teaching or abusive teachers. Sometimes they can have problem in the family in the form of illiteracy or single parent with low socioeconomic status, and sometimes the parents can have very high expectation. There can be a violence in the family that can affect their school performance. Here the child, the adolescent themselves can have some chronic diseases or anemia or mental disorders or some kind of abuse in them, or learning disability or speech and language impairment or hearing impairment or visual impairment, that can affect their school performance. These things need to be identified early, because any poor school performance itself has an impact on their psychosocial health, because they can have low self-esteem, and it can lead into stress and aggressive behavior, anxiety, and further lead into depression and school dropout, and they can go in for other high-risk behaviors like drug abuse or suicidal tendencies and sexual promiscuity. These problems can be added one by one. If we identify early, we can intervene and follow them up in a right way. And coming to the resilience is an ability to adapt in diversity. Protective abilities and self-competencies determines the resilience. The WHO life skills only empowers them to get these things, and they become more resilient. And WHO says some 10 basic life skills which are essential to get this as a protective mechanism, because the self-awareness and the empathy and the interpersonal relations, effective communication, critical thinking, creative thinking, decision making, problem solving, coping with emotions, and coping with stress. These things are essential basic life skills what the adolescents need to know. Nowadays, we have the health education programs happening in the school, especially the adolescent health education is running in a big way, because it helps in giving an anticipatory guidance to them to protect themselves in the form, because we give education in the form of nutrition education, or how they have the stress management, or how to get away from the screen time, and how to protect themselves from the high risk behaviors. All these things in the form of guidance can be given through school education to the adolescent girls and boys. So finally, the optimal adolescent development depends on the adolescent counseling and ethical and adolescent friendly approach, and timely referral for any mental health problems, and make them be a resilient person by giving a positive environment by imparting this WHO life skills. This is my last slide. Thank you. Thank you for the opportunity.
Thank you, ma'am. I would now request the next speaker, Dr. Divyalakshmi, to kindly share and the screen and take over the proceedings.
Let me know my slides are visible. Anyone?
Yes, slides are visible.
Thank you, sir.
Thank you.
So thanks for the warm invite from IAP CCB for allowing me to speak on this important topic, adolescent obesity and metabolic syndrome. So the objectives are like, to give an introduction about obesity and the metabolic syndrome, and to discuss about the approach and management perspectives. So why adolescent obesity is worrisome? See, this is not something new. These have been proven in multiple studies that, obesity itself is an emotional or a psychological burden to the child. And an obese adolescent is more likely to become an obese adult. And they are at a higher risk of non-communicable diseases. And studies have proven that being obese alone reduces the lifespan of the child by 5 years. And it also increases the healthcare expenditure, which is what we will see in the next few slides. So first thing, definition, how to define obesity. We are using IAP charts. It is color coded. The orange line, which is the BMI of adult equivalent to 23. Okay. So that is called as the overweight line. And the red line, BMI of 27 adult equivalent, which is called as obesity. Any interested PG students who want to learn which percentile is what, I have given the table below. So any BMI that is falling between the overweight and the obesity percentile line is called as overweight, and any BMI that is falling beyond the obesity line, it is called as obesity. Okay, so why we have this kind of different cutoff compared to CDC or other charts is that as Asians, we are much thinner and we are at a higher risk of metabolic syndrome compared to the Western population. So that is why our BMI needs to be much lesser compared to what the Western data says. And we also need to know the definitions of severe obesity and its classification. So there is something called as class 2 obesity, and then we have class 3 obesity. So class 2 obesity is when the BMI is falling more than 120 to 140th percentile of the 95th percentile, or in other words, BMI more than 35 or to 40. Okay, so that is class 2. Class 3 is when the BMI is falling more than 140th percentage of the 95th percentile, or BMI more than 40. So whichever is lower, we take that cutoff to classify into class 3, class 2 and class 3. Why this is needed? Again, when you plan to start the child on pharmacotherapy or a surgical management, again, these classifications are very important. And then, like, as I said, Asians, we are thinner, but then like we have excess body fat. So there is a possibility that the child may be having a normal BMI, but then their body fat is excess. So how to confirm that kind of things? Then we need to use other parameters like waist circumference, wrist circumference, DEXA scans, and then bioelectric impedance analysis. So when we talk about obesity, where do we stand? We stand among all the 250 nations that is surveyed. So we are at 174th rank. And the overall prevalence of obesity is 3.07%. Even though the number is looking very small, US is at 21%. Even though the number looks small, 3.07%, but number-wise, we are more. Like, in fact, we are the second highest globally next to China. And if you look at the NFHS 5 data, there are about 5% of children aged between 10 to 19 years who are overweight and obesity. And there is an increasing or emerging trend of obesity even in rural population. And as I said, the economic impact because of obesity is going to be huge. So 2.5% of GDP. So every year, I mean, you all know that the GDP spent on health expenditures are being, reduced on a yearly basis. So I don't think like, spending 2.5% of our GDP on obesity alone, obesity and its, expenditures alone is going to be, nowhere possible. So moving on to etiology. So broadly, etiology of childhood obesity is classified into monogenetic disorders and then syndromic disorders. You have the classic endocrine conditions and then the insulin dynamic disorders, which are in other ways, the commonly seen exogenous obesities, which are polygenic in inheritance. And then you have hypothalamic obesity, leptin resistance, Rohad syndrome, and those kinds. So monogenic, so we have the leptin deficiency, leptin receptor deficiency, POMC mutations, and the melanocortin receptor mutations. And then syndromic disorders, some examples are like Prader-Willi syndrome and Bardet-Biedl syndrome, Cohen syndrome, Alstrom, etc. Endocrine conditions, hypothyroidism, Cushing syndrome, pseudo-hypoparathyroidism, and growth hormone deficiency. So this pathway, before we move on to what is monogenic or syndromic obesity, is very important because this adipocytes which produce the leptin, it's an anorexic hormone. So when it acts on the leptin receptor in the arcuate nucleus of the hypothalamus, it stimulates the POMC peptide and its receptors that acts on the, which produces melanocyte stimulating hormone, and that acts on the melanocortin receptor, thereby decreasing the food intake, giving a feeling of satiety, and then decreases the food intake. On the other hand, when there is leptin deficiency, or when you have a deficiency of POMC or the melanocortin receptor mutations, that satiety feeling won't happen and there will be hyperphagia. So it is this basis, the medications which are indeed used in pediatric obesity are derived this way. So when you have a leptin analog or a drug that can act on the POMC receptor or the melanocortin receptor, is going to give you a satiety. So when to suspect monogenic or syndromic obesity? Extreme or early onset of obesity before 5 years of age. This is very rare. Less than 7% of pediatric obesity are monogenic, and genetic testing is recommended only in these conditions. And then other syndromic obesities, you can actually broadly classify them into whether they have a developmental delay or whether they present with a developmental delay. So if they have a developmental delay, one classic example will be LMBB syndrome or Prader-Willi syndrome. And without developmental delay, you have Alstrom's or leptin pathway defects. And then moving on to risk factors for obesity, the first and foremost thing is the birth weight. So as you can see in the picture, both ends of the spectrum, underweight and as well as overweight, like means SGA and LGA born babies are at higher risk of landing up with obesity. So is children born to diabetic mothers, prematurity, and mothers with preeclampsia and maternal undernutrition. So it is at this context I wanted to highlight the importance that I have been telling that Indians, we are thinner compared to our Western counterparts. So this was first appreciated by Dr. Chitranjan Yajnik in 2001. So as you can see in this picture, so at the age of diagnosis of type 2 diabetes, Indians are at least 10 years younger compared to the UK population. And we are much thinner, we have lower BMI, but our fat mass is much more, thereby leading us to have more insulin resistance. So this classical picture, which was published in Lancet, if you look at both Dr. Yudkin and Dr. Yajnik both have same BMI, but if you compare their DEXA scan pictures, Dr. Yajnik's DEXA scan picture shows more darker image, which means the fat mass is much more compared to Dr. Yudkin's image, which could be a possibility that, look-wise, if you see, Dr. Yajnik looks much thinner compared to Dr. Yudkin. So, maybe the reason that he is SGA born and he is not more physically active like Dr. Yudkin, who is a marathon runner. So those are some possibility. With that in context, the next risk factor for obesity will be weight gain during infancy and childhood. So by 3-4 years of age, children are expected to be, thinner, on their thinner end. If children continues to be on the overweight trend, if that is also called as adiposity rebound, they are at higher risk of landing up to be an adolescent with obesity. Same way, non-breastfed children are at higher risk of obesity. Early puberty, by the way of growth getting stopped early because they have attained puberty early, they are at a higher risk of obesity. And weight gain during adolescence, 17.5 times higher risk of landing up to be an obese adult. And then we have the genetic and the hormonal issues. Another important thing is like drug-induced physical inactivity or physical disability as well. So where do we stand on physical activity perspective? So we are at C- and D scoring. Many of the data that has been collected for this report card, we are at incomplete, and I hope over the next few years, majority of these things, we have some scoring system, and then we are able to compete with the Western world. And how to approach a child with obesity and metabolic syndrome. So first is to identify a child with obesity and then classify whether it is pathological or an exogenous obesity, and then identify comorbidities and then proceed for further evaluation. So case 1, we have a 12-year-old female child who came for a general health checkup, always been a healthy child, not otherwise symptomatic. So examination wise normal. Can anyone say what is the abnormality here? So I think only I'll only proceed with the thing that so you can see that the height is within the normal range. In fact, the child looks like quite taller for the mid-parental height, but the weight is also more. Okay, so here we have a child that whose height is not compromised, but having more weight, and the BMI is beyond the obese percentile. So this is a classic case of nutritional obesity. Why I'm saying nutritional obesity? Because height is preserved. We have a 16-year-old boy here. He is short for the mid-parental height in this case, and he is also about 100 kilos. So this is the clinical picture of the child. You can see the typical almond-shaped eyes, morbid obesity, and the hypogonadism. And he is a proven case of Prader-Willi syndrome. And then we have this kind of retinitis pigmentosa, hypergonadism, which is classical case seen in Lawrence-Boone-Bardet-Biedl syndrome. And then we have the brachydactyly associated mental retardation and short stature, which is classically seen in pseudo-hypoparathyroidism. So this is a child with iatrogenic Cushing syndrome. She's a case of SLE and on continuous huge doses of steroids and landed up with the Cushing syndrome. You can see this is her growth chart. You can see that she is short for her age, and then she is also obese. This on a head-on-head-to-head comparison with the nutritional obesity in the first case that we have discussed, notice that the height is preserved in nutritional obesity, whereas in pathological obesity, it is short. Children will be short. Moving on to evaluation of obesity, a thorough medical, family history and developmental history is very important. Any drug intake, diet, physical activity, sleep, that is very important. And then history pertaining to complications and the comorbidities one has to take. Anthropometry, special mention here is the BMI, measure height, and then, waist circumference. Because it is indirect evidence of insulin resistance. So IDF criteria says more than 90th percentile, but the Indian criteria demands to use 75th percentile as the cutoff, and we have the waist circumference data for Indian children as well. And dysmorphism, pubertal assessment, skins, joint, and extraocular movement all has to be evaluated. Comorbidity screening, this is very important. Ideally, it has to be started in all obese children more than 10 years of age. Less than 10 years of age also you can do, provided if there is a strong family history like diabetes mellitus, hypertension, etc., or a young onset stroke or ischemic heart disease or so, you can evaluate at a young age as well. And overweight children more than 10 years, if they have a comorbidity or a risk factor with the family members or an abdominal adiposity, waist circumference more than 90th percentile, please do investigate these children. Otherwise, a routine evaluation, endocrine evaluation as well as genetic evaluation is not needed in most of the obese children. So, complications with obesity. So this is severe acanthosis nigricans this child is having. And also this child was having these kind of stretch marks, which are simple obesity stretch marks. Compared to this, in contrast to Cushing syndrome, the striae will be violaceous or purplish, whereas this is whitish striae, and this can occur all over the body. And presence of skin tags, which is again an evidence of insulin resistance. And this kind of lipomastia or gynecomastia is more common in children with obesity. And another more complication will be most important thing that boys are brought to me is the appearance of small appearing penis, or and when you examine it, it is actually the buried in penis in the suprapubic fat. Complications of obesity, name any system, you will have complication in that particular system because of obesity. But I would like to highlight a few things here because pseudotumor cerebri. So most of the obese children who are having headache, and if they have a eye and ENT checkup that is turning out to be normal, please do evaluate for pseudotumor cerebri. And also specifically look for snoring, breathing difficulty during sleep, or something like that. So that will point you towards obstructive sleep apnea. Orthopedic issues, okay, slipped capital femoral epiphysis, flat foot, and so on are more common in obese children again. So that needs specific orthopedic interventions. And then evaluation for non-alcoholic steatohepatitis, okay. So these are some of the common complications that get missed when we evaluate. Otherwise, everyone gets evaluated for diabetes, hypertension, dyslipidemia, etc. But these are certain things that gets missed out. And also psychological burden. So eating disorders and other depression, anxiety disorders are more common in children who are obese. So moving on to comorbidity screening. So HbA1c is also nowadays becoming a reliable marker to say whether the child is having pre-diabetes or not. So 5.7 to 6.5, it is pre-diabetic range. And a fasting plasma glucose more than 100 but less than 126 is impaired fasting glucose. And impaired glucose tolerance is when the 2 hours OGTT sugar values are more than 140 and less than 200. Diabetes, you diagnose when the HbA1c is more than 6.5, a fasting blood glucose that is more than 126, and then 2 hours OGTT or a random plasma glucose that is more than 200. Dyslipidemia, so this is the cutoff. So I use NHLBI criteria rather than our Indian cutoffs. Because that is quite sturdy, and it is proven in multiple studies that these are the acceptable levels. And hypertension for adolescent perspective, I think it is very safe to use a cutoff of 130/85 systolic and diastolic BP respectively. Otherwise, we have this height percentile charts and the cutoffs. And there is something called as, metabolic dysfunction associated steatotic liver disease. This is also called as previously NASH or NAFLD. And the one enzyme, if you want to do, that will be, SGOT, that has to be more than 80 international units. And then you can also use GGT and use the laboratory cutoffs. So now we have the metabolic syndrome. So the most important criteria, which is highlighted in pink here. So it's the waist circumference. So IDF criteria says to use a waist circumference more than 90th percentile, and triglycerides and any one of the rest of the 4 criteria, any 2 of the rest of 4 criteria. So which is triglycerides and a low HDL, or hypertension, or a presence of diabetes, or a impaired glucose tolerance, or a impaired fasting blood glucose. So FBS more than 100 or a known type 2 diabetic will be the 4th criteria. So increased waist circumference plus any 2 abnormalities will form a criteria for metabolic syndrome in adolescents. And the difference is not much except for the obesity cutoff when you between 10 to 16 years or 16 years and above. So 16 years and above, we treat like an adult. Okay, so we use adult cutoff of 94 and 85 centimeters. And then PC4S in selected patients, if they have oligomenorrhea or hyperandrogenism, evaluate for that. And then lipomastia or gynecomastia, then do hormonal evaluation. As I said again, obstructive sleep apnea or psychiatry assessment, eating disorders or a behavioral disorder. If positive history, please refer to appropriate specialists. And one important thing I want to highlight here is, the criteria for PCOS in adolescents have changed. It is only now either clinical or biochemical evidence of hyperandrogenism and a positive history of menstrual irregularity. So if the cycle is less than 20 days or more than 45 days, we take as menstrual irregularity. So these 2 criteria is must in order to label a child as PCOS. So you can have like the picture, there are varying grades of hirsutism here. And then this kind of severe acne, like a comedone or a pustular kind of acne. And then the acne that has led to scarring, so indicates that the acne is of a severe grade. Apart from this kind of hirsutism, see, this is again hirsutism, hair growth in the midline and also surrounding the nipple areolar complex. And then this is androgenic alopecia, thinning in the the vagad area thinning agradhu. So in the frontal and the central aspect of hair loss is again androgenic alopecia. One thing to note is that ultrasound criteria of polycystic ovarian morphology is not taken as a criteria for polycystic ovarian syndrome in adolescents. Moving on to management of obesity. So it has to be intensive. See, the recent AAP guidelines says that, obesity has to be treated like an acute condition. Okay. So it has to be treated like when a child is down with the influenza pneumonia or something like that, how acute management that will be. So that kind of an acute management, one has to concentrate on obese children as well. So it has to be intensive, age appropriate, culturally sensitive, and family centered. So more than 7-year-old children, we have to target for weight loss followed by weight maintenance. So some of the guidelines are like, decrease the consumption of fast foods or processed foods, reducing the usage of sugar, and the elimination of sodas, the soda drinking, and then consumption of whole fruit rather than fruit juices, and improved knowledge about the nutritional labeling of food. I just put this picture here just because I wanted to highlight the audiences, regarding, see, this is the This is mandatory now, even in India, the nutrition label front of package nutritional labeling. So this is in the US. You can see that, per pack, it is 210 calories. Whereas look at the condition here, it is per serve, per 16 grams. 16 gram is one serve, and this is 130-gram package, and it is mentioned here as 85. So even if our patient is quite knowledgeable to read nutritional labeling, this is like kind of, misleading information that is being given. So if a person is buying, like, it simply says that the person has to do a lot of mental maths before buying these things, or better not to buy only. Okay. And then portion size control education. Okay, so how, why this epidemic has happened, if you look into very clearly, like, over the years, from 1960s to till now, the plate size has increased without our knowledge. Okay, so it was initially 8.5 inches, and now it has become like 12 inches. And also all the junk food, the portions, they have increased. I mean, previously during when we go to a theater, like during our childhood days, we used to give to one small packet for like 2 rupees or 3 rupees. But now we share a bucket of popcorn for, some 200, 300 rupees. So that is the portion size has, like, become magnanimous nowadays. So having that control on portion size is very important, and parents and as well as child needs to know, have an idea about the portion size control. So moving on further regarding child and family oriented dietary guidelines. So reduced saturated dietary fat, and then increased intake of fibers, fruits and vegetables, and identify some, eating cues or boredom, which will make the child eat constantly rather than, eating at one particular point of time. With constant grazing or like constant eating, that won't happen. So this is something for an adult. Our National Institute of Nutrition recommends to eat this way. Like half of the plate has to be your fiber-rich content, and then 1/4 of the plate can be your carbohydrates, and the rest 1/4 can be, fats and proteins in different combinations. And you can have about 250 to 300 ml of milk or curd for a meal. Okay, so same way. And it can be, extrapolated to children as well, because, in a 12-inch plate or a 25-centimeter plate for an adult or for a teenager, if we can, almost give this kind of a plate method kind of explanation, maybe probably that will give an idea towards, portion size control and also reducing junk food intake and so on. And question again asked by many teenagers and their parents is like, what about very low calorie diet and intermittent fasting? One thing is that it is not recommended in adolescents because there is lack of long-term safety data, and with the prolonged use, there is definitely a nutritional inadequacy, and also compliance to this kind of diet for a prolonged period of time is going to be an issue. However, it can be considered in children who have completed final adult height, and then they have failed all these conservative managements, conventional managements, and then children with severe obesity, and then children having comorbidities. So activities guidelines. So WHO recommends a minimum of 20 minutes to start with. Okay, so to start with, minimum of 20 minutes, moderate to vigorous physical activity with a goal increasing up to 60 minutes. And then limit the non-academic screen time to 1 to 2 hours per day. And then, evaluate for psychosocial comorbidities when in need. So the say is that, eat 5 portions of fruits or vegetables and reduce your screen time to 2 hours, play for 1 hour, and then reduce all the 0 to all the junk foods. Pharmacotherapy for obesity, please note that this can be tried only in adolescents who have completed their final height, or in children with class 2 obesity with comorbidities, or in class 3 obesity. Orlistat is FDA approved, but please do note that it causes steatorrhea, and that is a severe adverse effect children faces with. And then we have liraglutide and semaglutide, which are GLP-1 receptor agonist. Phentermine and topiramate extended release tablets that again approved by FDA for children more than 12 years with a BMI of more than 30. Semaglutide is once a weekly preparation, and it can be imported, with a little bit of difficulty it can be imported. And metformin in children who have impaired glucose tolerance. And setmelanotide. So this is the drug, in children who are having hyperphagia. This drug can be used because, especially in conditions like PYMC deficiency or leptin receptor deficiency. Then bariatric surgery, again, class 2 or class 3 obesity children only, we can use this. And once again, the child has to complete puberty and as well as attained final adulthood. It should be done only in experienced hands. And the common procedures are sleeve gastrectomy and gastric bypass. So a sample management plan will be, this is how it goes. Okay, so the activities, the diet plan, so far we have discussed, everything is called as prevention plus. This needs to be continued on for 6 months at least. And then if the child is able to achieve weight loss or maintain weight loss, continue with the prevention plus. If there is no response, then we move on to structured weight management. This is where personalized trainer, personal dietitian, all those people come in. And then, if they able to achieve weight loss, then continue with the structured weight management. If there is no response, then comprehensive multidisciplinary intervention, and then you can consider about tertiary care interventions like pharmacotherapy or bariatric therapy with more frequent physician visit. All these things can happen. See, the basic idea is to, acutely manage childhood overweight and obesity. So prevention is the only solution for children with obesity. But we have only the control over, the child and the family. See, we can only say things to the child and the family, but there is much more bigger influences are there. Okay, so organizational, when the child goes to school, and the peer influences, and also the healthcare setup. Okay, right? So these areas, school and the peer influences, there is no mandatory standard for food that is provided. We say eat healthy, but in the school canteen, they'll sell puffs and all, cutlet and all those things and all. And in the community level, like the built environment, that is again very important. If there is no place to go for a play or an activity, that there is no park in the surrounding. So how do you expect the child to go for some activity, So that again, a community plays a lot of role in it. And then society, media exposures and advertising industry. Okay, so see, we have kept the one thing that the government has done so far is kept mandatory nutritional labeling, but that is not enough. So there need to be a strict policies and regulations on, promotion of unhealthy foods and drink using children, and such kind of ads to be prohibited during prime time where children watches television. And also, once again, no fiscal policies on healthy food. So see, in our country, we don't have, subsidies given for fruits or vegetables. And then there is no ban on trans fat products. There is less political will and support. Of course, it is getting better, but it is still at a very lower level. And then there is no such national guidelines on obesity treatment from the government sector. Even though IAP has a specific guideline, but it is yet to be approved and taken up by the government. And there has to be a rampant monitoring of obesity and its surveillance and its associated non-communicable diseases. So the key messages are there is an alarming increase of obesity in children. So as they say, about 2.7 crore children by 2030 India is going to have. And this is a persistent epidemic and international problem. Exogenous obesity, which is more common, has a polygenic inheritance, and prevention is the only solution. And it should ideally start from preconception, target the adolescent girl, and make them have a good physical activity and a nutrition. And it should continue post-conception as well. So up to 6 months exclusive breastfeeding, followed by a adequate complementary feeding, healthy diet, etc. And evaluation is needed from children more than 10 years of age if they are obese. And ideally, I would suggest to start even at a overweight stage. And specific investigations like PCOS, OSA, etc. In selected cases, you refer to specialists and get evaluated. And intensive lifestyle intervention at several level is needed, like from starting from child to national level policy. And think about pharmacotherapy and bariatric surgery only if the conventional therapy has failed. And also, one can also think about these things in class 2 and class 3 obesity. Thank you. So these are pictures I took from our obesity camp. And these are children dancing happily during our Zumba session in one of our camp. And I thank my team. That is, we have a nurse educator and a dietitian participating in our OPD. We have a special day allotted in the week for obesity clinic. So I thank my team once again, and I thank IAP CCB for giving me this wonderful opportunity. So I'll stop sharing here. Thank you, everyone.
Thank you so much, Dr. Divyalakshmi. Moving on to the next speaker, of course, Madam needs no introduction, and Dr. Subbu has also spoken so much about her. Welcoming Dr. Pungadi Bala ma'am to speak about mental health issues in adolescents. Over to you, ma'am.
Good afternoon, all. Hope I'm audible. So, coming to the mental health issues in adolescents. I won't be able to change my slide.
Slides are not changing, ma'am. Probably you click on the slide, click on the screen, ma'am, once.
Okay.
Yeah.
I think this. Okay. The aim of this presentation is, as a pediatrician, you're the first point of contact. So when to do the referral to us, and what do we do for those patients? So what are the common mental health problems? Generally, they're coming to us with the kind of not very specific symptoms. Generally, that emotional difficulties, stress, and behavioral difficulties. Then, of course, the functional disorders. I have highlighted 4 things. It doesn't mean that these are all an important thing. The one who was not highlighted, I'm going to talk it in a separate slide. Just the highlighted one, I'm going to talk it quickly because we have got a lesser time. So most of the adolescents, or as Dr. Sarala said, they're quite stressed because of the environment. Mainly the study nowadays, they are living in a very competitive world. They don't have time to play and all, but they are having the time to use the gadgets. I will come back to that later. So that's an important thing. Another one, the emerging personality disorders. We don't diagnose any personality disorders until they become 18. 18 should be completed.
Ma'am, sorry, ma'am. Can you please come closer to the mic, ma'am?
Okay. Now, is it audible, sir?
Better, ma'am.
Okay. Usually we diagnose the personality disorder only when they reach 18 completed, because we are giving some time for them to develop their personality until 18. So before 18, if they show those kind of the symptoms, like repeatedly they're coming with some somatic symptoms or self-harm, or lots of low self-esteem, and like kind of they feel like lots of family dynamics and the poor academic performance kind of things. So we call it as it's a kind of the emerging personality disorders. Then the gender identity disorder. Nowadays, the kids are highly influenced with the social media. So they got confused with this kind of lots of terms, gender identity, and also they're worried about some sexuality. They started talking about all these things. This week I had one 19-year-old that came to me. I think not 19-year-old, 15-year-old. She's in only 9th standard. But in her school, they have done the awareness program about LGBT. Then she got confused, because sometimes we need to think, do we really need to do these kind of the awareness program in this age group? Because sometimes when we are exposed to that other kind of things, the kids are really confused. Then she used to come to me for the counseling to clarify in everything. Then obviously the developmental disorders includes ADHD and autism, then intellectual disability and the learning difficulties. So what are the common behavioral problems? Mainly, I know as a pediatrician, you will also hear these kind of problems. Morning எழுந்திரிச்சோனே எதுவுமே பண்ண மாட்டேங்கிறான் ஸ்கூலுக்கு அனுப்புறதே ப்ராப்ளமா இருக்குன்னு. So mainly they're not doing the morning routines because of this poor sleep pattern, because everyone is using the gadgets. Then adamency, because nowadays we are all having only one or two child, then we are giving the comfort zone. So the adamency is becoming a main problem. I do get lots of cases just for the parenting guidance, for only the reason is my child is very adamant, doctor, what shall I do? Then obviously because of all this online Swiggy and Zomatos, many adolescents are demanding the parents to buy snacks or the food every day. That is happening. Then anger issues, if they say no, it can lead to violent behavior like hitting parents, breaking things and screaming, then sometimes lying, stealing, run away from home. Then the most importantly, internet addiction. Internet addiction was added as one of the mental health disorders in ICD-11 and DSM-5 2 years ago. It is termed as internet gaming disorders. Obviously, we all know that how it affects the academic performance. It can increase the violent behavior and it can lead to cyberbullying. Many parents are coming to me, doctor, I have not noticed they've used money up to lakhs because they will be able to use the online credit card or the debit card. So we have to be, then lots of cyber bullying is also happen. So it is another important thing we need to look into that. So what do we do for this internet addiction? To be honest, it's only the parenting stuff. Because sometimes, no, if you don't supervise the children now, they are addicted to the internet. If you don't limit the gadgets, because many parents asked me, like, is that what we have to do? Then I said, yes, there is no magic to just give some medication and change the internet addiction. It is only the typical parenting and make the child to come under the boundaries. Especially we have to follow it as well, because currently I think everyone is having the separate mobile phone or the separate gadgets, and the family time has been reduced. So obviously parenting counseling and the individual counseling, some cases, no, when they are very violent, because most of the teenagers who come to me, the parents are giving this kind of complaint that, doctor, when I try to remove the gadgets, they're becoming very aggressive, they're hitting me, I don't know what to do. Then in those situations, if the parents are not able to limit the gadgets use, they become very violent, or sometimes they will threaten like, I'm going to commit suicide if you don't give a phone and those kind of things. And sometimes I have admitted many adolescents just for this purpose of removing the gadgets. Then I'll tell them, okay, when you go home, the gadget, you're not going to get your mobile phone, you're not going to hit them. Because unless the adolescents understand, the teenagers or the child, even 8-year-old, 9-year-old are doing it, the consequence of like, if I don't limit my gadgets time, the parents will do something. Most of the time parents don't know what to do, because both of them are working, grandparents are dealing with this issue. Then finally they take the advantages, then teenagers are controlling the parents. In that case, no other option. I have admitted many adolescents just for the purpose of letting them know the consequence. Otherwise, if you hit them, you'll be back to the hospital, then you have to be in the hospital. Then it really works. Then to reduce the anger issues, we may give some kind of SSRIs and the medication as well. And associated with most of them, they may have comorbid anxiety and depression. Then we use the medication. But generally, parenting and individual counseling only will help. Just to discuss some case scenarios, a 13-year-old girl who has the diagnosis of intellectual disability, delayed development, she speaks only single word, she's attending special school, she lives with her parents, she did not attend the school for a week, she was aggressive and irritable for a week. That's the reason they came to me. Then they also noticed she had a rolling up of her eyes. So she's on this multiple medication. You can see that there are 3 antipsychotics like risperidone, aripiprazole, and pimosides or antipsychotics. Other 2 are coming in except as ADHD medication, but it was given to reduce her the anger. The most important thing is the girl is taking this medication, I think nearly for the 6 years. She didn't have any psychiatry follow. The reason I added this case is, sometimes if you see any adolescent with the kind of multiple medication, especially the antipsychotic, ask them whether are they having the psychiatric follow. Because the antipsychotics, no, it reduces the threshold for the seizures. So obviously it increases the episodes for the seizures. So it's really, they should have a regular follow with the psychiatrist. Then if the behaviors have been settled, we could reduce the dose, or some cases we can stop it. So in this case, she was started on antiepileptic medication, but I have also reduced the antipsychotics as well, then she was fine. Then when someone comes to you with the challenging behavior, mainly with the special need kids, teenagers, you have to look for the cause, either physical health, like any constipation, or tooth cavities, or environmental changes, because the children react to the environmental change. Like for example, if the father, I have a couple of teenagers with autism, if the father goes away from home for work purpose, they can't control their behavior. They will cry, they will scream, and all those things. So, or some changes happening at the school, they react to that because they are more sensitive. Then obviously the abuse, it is not only the physical sexual abuse, the emotional abuse, because sometimes the parents lose the control of taking care of them. So that is also needs to be ruled out. Then obviously the medication side effects, as in this case. The second scenario, 11-year-old boy moved from US, lives with mother. A father lives in US. He complained of whole body jerky movements for 2 years on and off. EEG showed some abnormality, so he was seen by the neurologist, started on sodium valproate, but after taking the 6 months, no improvement. Then when I took the history, then I found that his symptoms got worsened while doing the homework. Then mom got upset because he's not doing anything, then shouts at him. He was hyperactive as well. Then also noted when they visited US for the summer holiday, for the 2 months of summer holiday, no episodes. So obviously it is stress related something, but actually I diagnosed it, it's a kind of the tics and mild ADHD. Because if it is the tic is single symptoms like vocal tics or eye blinking or any limbs movements, it's easy to find out. But sometimes when it occurs as a whole body jerky movements, many of us get confused with especially EEG showed some kind of abnormality, then we get confused with it could be an epilepsy. So it's really important to get the history to rule out whether it's a tic or it's an associated with seizures. So finally, parents had a counseling to reduce the stress regarding the study. Then methylphenidate started. Then, so what is tics? It is an involuntary, rapid, recurrent, non-rhythmic motor, involuntary movements, or it could be a vocal production. It starts sudden onset, purposeless movement. Usually, it involves the circumscribed muscles groups. It increases due to stress. How do we treat them? First, we have to explain to them. Usually, it gets better when they go to adulthood. Sometimes, if it is not settled with relaxation techniques or distraction techniques, we may start the clonidine or benzodiazepine. The next one is the functional disorder. I'm sure you will see lots of functional disorders nowadays. Any kind of somatic symptoms like any cyclical vomiting or functional constipation also, just they complain it, but when you check it, there's no constipation. Then abdominal pain, headache, abnormal movements of the limbs like non-epileptic seizures or convulsion disorder, which is, it's a kind of stroke. Some adolescent, they will say that I can't move my right leg and right left arm. Then finally, when you look at them while they are sleeping, they're able to move it. So it's all part of the functional disorders, even though in psychiatry they have the separate name like convulsion disorders or somatoform disorders. This is more common in girls than boys. Obviously, we need to identify the stress, then we need to treat them. And then coming to the other case scenarios, 11-year-old boy was admitted to the ward for the strange behavior for a week. They have done all the investigation, including lumbar puncture, MRI, and everything was normal. He was referred to me with the Curie psychosis. Then when I spoke with him, just his words are, "You're evil, go away, I don't believe you," those kind of weird talk. So when I explored the history from parents and him, other things, when you talk about his interest, he's perfectly fine. But when you talk about any treatment, about the hospital, he's literally talking weird. Then I found that a week before this admission, he was admitted in other hospital. He was having lots of injection and whatever the IV fluids. So the child was having some anxiety towards the hospital stuff. That's it. So as soon as even the mother mentioned to the doctor, as soon as the nurses or any doctor entered into the room, he started saying all these things. So it's a simple thing. When we take the proper history, we can easily find out it's only the hospital anxiety, nothing else. There is no evidence of psychosis. Then we discharged the child. So what I'm trying to say is sometimes if we can't come to the conclusion, like kind of difficulties, we need to spend some time and get the history. Then half of the mysteries can be resolved if we take the proper history. For this, you need a psychiatrist or the psychologist help. The next case scenarios, It's a 14-year-old boy admitted to PICU following an overdose of 16 tablets of paracetamol or something. No significant post-medical history. He was perfectly fine. He's studying 9th standard. But when I talked with him, he said, I don't want to go to school because I will get a punishment because I got low marks in my last test and all. That's it. Still, in many schools, they are giving physical punishment. So, or sometimes when they have some learning difficulty, they don't want to have this punishment. Even parents are not understanding. The teachers are also not understanding. So, children will try to go into that other route, like refusing to go to school, or they are trying to harming themselves, like self-harm, scratching their arm, or they take that overdose. So we need to know this. We all know that, I think so. Suicide is the second most common cause of death among young people in India. India has one of the world's highest suicide rates for the youth aged between 15 to 29 years. Risk factors are obviously family history, poor coping skills, stressful environment, and substance abuse. The prevention, obviously, it's a good support from family and outside to improve the coping skills. So we have to create an awareness in the school as well as the other healthcare professionals regarding the suicide. How to differentiate the self-harm with the suicide? Because if anyone cuts their hand, it doesn't mean that they want to commit suicide. If you identify with these kind of cases in your OP, you just ask them, what do you want? What do you want it to be happen? Like, why did you do this? If you ask them, did you have the suicidal thoughts at the time? Do you want to end your life? These kind of direct questions you can ask. The children will say that no, I don't want to die. Just I cut my hand to relieve my stress. I feel better after cutting my hand. If they say that, this is a kind of the self-harm. It is not the suicidal intention. So it's a kind of the cry for help. When you explore it, obviously they come up with lots of depression, anxiety, or any other or study-related stress. Then you can refer them to the psychiatrist or the psychologist. How do we deal with the school refusal? First, we need to identify the cause. The underlying cause could be learning difficulty. Like yesterday, I had one child, I assessed the child. The child is in the 10th standard matriculation school, but the child can't even read 4-letter words like home. Even she doesn't even know the phonics. She can't even know what is 11 plus 13. I'm really surprised. I have seen many cases like that, how they have passed until 10th standard. Most of the cases they will stop in 9th standard. So it's really, then the child can't pass it. Then what she did, because she couldn't read it, she started becoming isolated from everyone. She's not having any friends because she's always bullied, like you are a muck, waste, so even the parents couldn't understand. They'll put her in lots of tuition, but nothing has been helped. Very unfortunate thing is no one has identified the child can't even read the basic words. So it's really important to check any child with a school refusal to rule out the learning difficulty. And obviously nowadays the gadget addiction is another cause. Then it could be a separation anxiety, even though it's common in primary school kids, even sometimes it happens in the teenagers as well. Then obviously bullying and stress related with studies, mainly when the adolescents are going to the integrated coaching from 10th, 11th, 12th, they are enormously stressed. The parents are not allowing them to come out of the those kind of integrated coaching because the cost is very high. So we need to identify the cost, then we need to treat it. So when I spend more time with the parents. Once the parents understand the situation, it's easy to deal with this. Then I'll also do the individual counseling. Then sometimes the school support is also needed. When the child is refused to go to school because of the exam fear or bullying, usually I'll give the letter to the school like, can you allow them for only exam or the part-time school like half day or the 2 hours, something like that. Slowly we have to build up. So the support from school is really, really important. Or sometimes if they have the learning difficulty, I'll ask them to change into easier syllabus, like from CBSE to metric or metric to NAOS, those kind of things. Because this is going to help in long run rather than passing that year. Medication is offered only for comorbid conditions like ADHD or depression and anxiety. The other psychiatric conditions, so the depression, anxiety, and OCDs are common. Obviously, when you take the history, you'll be able to find out. The anxiety could be generalized anxiety or separation anxiety, panic disorder, social anxiety. I think OCD, it becomes more after having the COVID because nowadays the kids are more like kind of they are looking into that hygienic purpose, and also they read a lot of information from the social media. especially regarding the kind of the sex education and all. When they start reading it, many kids are coming to me with, I'm having the intrusive thoughts about the sex and the relationship and the gender identity. Then they feel guilty for thinking about it. So it becomes like an intrusive thoughts, it becomes like an OCD. But when they come to us early, it is completely curable. That is an important thing. If it is a mild one, we will do only counseling. But if it is a moderate and a severe, we'll start the medication. As a pediatrician, if you want to rule out this initial screening questionnaires, you can use these kind of the questionnaires like SCAD1, that is screen for child anxiety related disorder, then hospital anxiety depressive scale, then Yale-Brown obsessive compulsive scale, eating disorders examination questionnaires, then perceived distress scale. Most of these scales are available in Google itself. Then coming to the psychosis, actual like typical chronic complex psychotic conditions, or like schizophrenia or delusional disorder, the bipolar disorders are not common in adolescents. Okay. So most of the time when they come to us with the psychotic symptoms like hallucination or the delusions, it is all related with stress or mostly depression and anxiety. So they will respond to the antipsychotic really well. Then if we help them how to manage those stress and the family circumstances or whatever the school circumstances, the prognosis is also very good. But definitely the psychotic cases, they need a medication. And of course, you will rule out other organic causes like the physical conditions. No, initially, they're like autoimmune encephalitis or brain injury, thyroid disease or brain tumor and epilepsy. Then another thing is eating disorder. It is not uncommon because of, again, social media usage. I think one side we are talking about the obesity. The other side, many youngsters are very conscious about their body image. They start counting calories, and they are restricting lots of food. Girls are, I think girls are affected more than the boys, but still even I have seen few boys with the eating disorder. So if anyone comes to you with the low weight, I know you will check all this nutritional kind of things, but also check their mental state. Just to identify the eating disorder, ask this one simple question. Are you happy about your body image when you see yourself in front of the mirror? If they say that I'm not happy, I'm either kind of, I need to lose my weight, then that is the kind of eating disorder. So we need to explore further. Then substance abuse, it is also not uncommon. Again, because of the social media, we are moving towards a westernized culture. In my clinical practice, the adolescents are asking, my father drinks, my mother drinks, why can't I drink? So this is the common scenario I'm exposing it. So we have to be mindful about what our kids are watching us, because we are, as I said, in westernized things at home. If we do it, it's okay. But if we drink at home, but if we expect our children shouldn't do it, that is not going to be possible. So again, we need to do the parental counseling only. Then again, many schools and outside, the peer group influence also one of the other reasons. So we need to check their peer group influence and what do they do. And mainly the supervision is needed to prevent the substance abuse. So what are the management for those kind of the mental health issues? It's a biopsychosocial model. Mainly we know that even in the depression or any other mental health issues, chemical imbalance is there. So we do use the medication. Then psychological support. Obviously, if you talk to the teenagers, they will bring it out. Lots of worries like, I don't like this, I don't want this, I don't have a friends, I can't study, it is stressful. Lots of things nowadays. Teenagers are very openly talking about their problem. So they need a psychological support. Obviously, the social supports from school and the outside of the family, because most of the time, both parents are working. The children are spending time with the internet. They're not having enough time to play, or they'll be engaged in lots of tuition or any integrated activities, especially when they come to the teenagers. So they're feeling very overwhelmed. Then that is the main triggering factors for all this mental health problems. So we need to address it. I think this was covered by, in pediatric OP, you could use this head screen. I think already Dr. Sarala has covered it. The management is mainly, it's a kind of the teamwork. We have to involve the pediatricians and the psychologists and the behavioral analyst, or whoever is available. Then they have to complete the assessment. Then if they need a therapy, it is not only the counseling, whether they need cognitive behavioral therapy or family therapy or parenting skills training, then the school programs to mainly they create the awareness, because most of the time some of the schools are supporting, some of the schools they're not understanding, they have the learning difficulty or the depression or the self-harming. They just think that Nivenune Panda, especially the somatoform functional disorders, as soon as they have some hyperventilation, they'll call the parents, they will ask the parents to take the child home. Even when we explain it, it's only the hyperventilation, just do some relaxation techniques in the health room, they'll be okay. Every time when they send the children home, the children don't want to stay in the school, so they get the habit of doing this, then they're coming back home. It's a kind of escapism from lots of school work. I have seen it. So it's really important to create the awareness about the mental health issues in the school. I'm sure as a pediatrician, you all will have many opportunity to go and talk in the schools. So please talk about these functional symptoms and the learning difficulties and those things so that they can be supported very well. I think that's it. Thank you so much.
Thank you so much, ma'am. That was a very wonderful talk. Then moving on to our final session of the day, requesting Dr. Ilayaraja sir to take over and speak about pulmonological issues in adolescents.
Yeah. Is my slides visible, ma'am? Hello?
Yeah, yes, Ilayaraja.
Yes, sir. Yes, sir.
Yes. Is my slides moving?
Yes, sir, moving, sir.
So this is the last topic of the day, common respiratory problems in adolescents. The program is running delayed by at least 30 minutes, but I will make sure it will get over in another 15 minutes. I still see around 40 people logged in. Thank you so much, all of you. So we know that there are a lot of physiological changes that happen during adolescence. What we should know is the lung development with regards to lung. If the lung development starts as early as in utero period, and it progressively improves and it peaks in the adolescent and the early adulthood. So what we should ensure is that the lungs remain disease free during this particular period, so that we can achieve the maximum potential of the growing lungs. So, what are the respiratory diseases that can happen in adolescence? So, what are the problems that can happen during this particular crucial stage of development? We all know the common problems are asthma, allergic rhinitis, and tuberculosis is now becoming increasingly common, and pneumonia is, as usual, a common infection. And somatic cough, we are seeing a lot of cases of somatic cough nowadays in adolescents, and chronic lung diseases are known to cause flare-ups during the adolescent period, and sleep issues also are common during adolescence. So we'll see one by one. First, we'll take asthma. Asthma control is in many adolescents we find the poor asthma control in
Sir, we are not able to hear you, sir.
Not audible, Ilayaraja.
I think we are lost, sir. He's not there. Just call him. Lakshmi, can you call him?
Yes, sir. Let me just check, sir.
Yeah.
There was a connectivity issue. He's just joining back in a.
He's joining back,
in a
2 minutes. ma'am. You
Yeah.
can share பண்ணுங்க. இப்ப பேசுங்க.
Am I audible, ma'am? Lakshmi, ma'am?
Yes, sir. Yes, sir.
Okay. I'm sorry, there was some technical glitch. So I was not audible. So I will continue from where I left. So these are the common respiratory problems that we see in adolescents: asthma, allergic rhinitis, tuberculosis, and infections like pneumonia. And somatic cough is now being increasingly commonly seen, and we see a lot of chronic lung diseases that gets flared up during the adolescent period. And the sleep problems are also not uncommon in this age group. Right. So what are the risk factors for poor asthma control in this age group, the adolescent age group? It can be biological, it can be psychosocial, or it can be social. So biological, the main problem is over usage of bronchodilators. So bronchodilators, when you are using it, going to use it very frequently, there is going to be down regulation of these beta-2 receptors. Because of down regulation of beta-2 receptors, so over a period of time, the medicines may not work, even with appropriate doses. The bronchodilators may not work, and the control is likely to be very poor. This is because of the wrong concept of not using a regular preventative therapy and relying solely on the bronchodilators or the beta-2 agonists. So this leads to frequent hospitalization, frequent healthcare visits, and the psychological causes can include stress, risk-taking behavior, and poor adherence. And poor adherence to treatment, that is going to be one major reason in adolescents that causes frequent exacerbations. And social causes include disorganized routine. Most of these children have a poor sleep routine, and they have a lot of family issues, and they're more exposed to smoke exposure also worsens the asthma control in adolescents. So how does stress affect asthma control in adolescents? Stress has got direct as well as indirect effects. So the direct effects can be due to chronic HPA activation, that is the hypothalamo-pituitary axis activation, or it can cause direct inflammation over the airways. So once the HPA gets activated, there will be a surge of catecholamines and cortisol. Because of this surge of catecholamines and cortisol, if it happens over a long period of time, as I told you, there will be down regulation of the glucocorticoid receptors and the beta-adrenergic receptors. All can cause asthma symptoms.
Sir,
Similarly,
sorry to interrupt, but your slides, we need to see them, sir.
it's not
The
moving,
slides. Yeah, slides are not moving, sir.
okay. I think there is some problem. Voice is audible, ma'am?
Yes, sir. Audio is fine, sir. The slides are not moving. We're still on the first slide,
Okay.
on the title slide, sir.
Yeah,
Yeah, now, yes, sir. Yeah, sir.
Now
You're
my
back,
slides
sir.
are moving, no?
Yes, back,
My
sir.
slides are moving. Yeah. Thank you. the indirect effects of stress or tobacco usage, that is smoking and the overweight and obesity because of stress and poor adherence to treatment, they can all contribute to poor asthma control in adolescents. So how do you manage asthma in adolescents? Pharmacotherapy is just one part of the treatment. The other part of it, it should be three-pronged. It should be population-based, it should be school-based, and family-based. What are the population-based strategies? We should be having a strict legislation regulating the marketing of tobacco products, and there should be youth-fronted campaigns against tobacco usage. That is one thing. School-based campaigns that can lead to peer-led support program should be there for asthma, and there should be asthma education program for the school staff also. With regards to family, there should be a smoke-free environment, and the self-management of medications can be allowed, but it should be under a family member supervision. So these are the management strategies. Coming to the next topic, allergic rhinitis. We all know the common triggers of allergic rhinitis is divided into seasonal and perennial. So it can be tree, grass, weed, seasonal allergens, or houses made mold, dander. There are perennial allergens. But what is of interest in adolescent is neither of these. It is the non-allergic irritants that like smoking, smoke exposure, or strong odors and perfumes, spicy or hot food, alcohol, pregnancy or hormonal changes. All these are exclusively seen in adolescent. That is what is the reason for worsening control in allergic rhinitis. So how does it impact the adolescent's quality of life? Allergic rhinitis impacts quality of life by more than one means. First is it affects the school performance. So it is believed that allergic rhinitis affects the school performance by more than 30%. And the learning and cognitive function seems to be disturbed in children with uncontrolled allergic rhinitis. And we all know that allergic rhinitis and asthma have a very close relationship. More than 60 to 80% of asthmatics have coexistent allergic rhinitis, and untreated allergic rhinitis can lead on to upper respiratory infection, sinusitis, hearing dysfunction, and dental problems as well. And allergic rhinitis can also lead on to adenoid hypertrophy, increased incidence of sleep apnea because of sleep disturbances. They can have excessive sleep and tiredness. Right. So what are the management strategies? Pharmacotherapy actually in adolescent allergic rhinitis, it comes as a last step. The primary steps are environment control, like avoidance of the irritants or the triggers, like smoking and strong odors, and healthy and balanced diet should be advocated, and good physical activity and avoidance of obesity. Already it has been dealt with in detail, and the sleep hygiene should be practiced in adults. All of these things we'll be discussing again. Right. Coming to the next important topic, tuberculosis. Tuberculosis in adolescents, even when compared with childhood, adolescent tuberculosis has a high incidence and prevalence. Why? Because one is the adolescents come into contact with a variety of persons, so there is a shifting social contact pattern, and there are so many immunological changes that are connected with the hormonal changes that occur during puberty. Because of this, the prevalence of tuberculosis in adolescents has gone up. But the problem with adolescent tuberculosis, the diagnosis can be tricky. It is not very easy because we all know it is a paucibacillary disease. So it is very difficult to confirm the disease with microbiological testing. So that is going to be one big problem with adolescent TB. What are the risk factors for Mycobacterium tuberculosis? Infection. So it is mainly the malnutrition. Apart from a positive contact history, the malnutrition seems to be one important risk factor. The other risk factor is smoking. With regard to progression of the disease, one is the undiagnosed and untreated infection and poor adherence to preventive therapy and malnutrition, HIV. All these factors can lead on the progression from the infection to the full-blown disease. Right. What are the prevention and treatment strategies? So for tuberculosis, we should have a early diagnosis and early treatment. We should maximize the infection control and preventive therapy for household contacts. And we should assess other adolescent health risks behavior. We have already seen Madam telling us about mental health issues, substance abuse, and even HIV screening is important in nowadays in the management of adolescent tuberculosis. And we should also monitor the treatment adherence from the start till the completion of the therapy. So these are the steps that are taken to prevent and treat adolescent tuberculosis. Coming on to the case studies, this is one of the cases that was referred to us by a pediatrician, 15 years old adolescent who was referred to us with fever and hemoptysis of 2 episodes. There was no contact history. with any tuberculosis patient. Chest auscultation revealed there was nil significant auscultatory findings. So X-ray was basically, there was not much of X-ray findings, but CT revealed a cavitatory consolidation here in the left upper lobe, and there was a lot of centrilobular nodules scattered over the CT scan. So we did the tuberculosis workup. Even though CBC was normal, ESR was elevated, but MAN2 was negative, sputum, AFB, and gene expert were all negative. So we proceeded with bronchoscopy, and we did a BAL from the left upper lobe, and this BAL detected Mycobacterium tuberculosis. So this child was started on ADT, doing very well on follow-up. This is one more case. This is a recent case. This child was 16-year-old adolescent girl who presented with hoarseness of voice and cough to the ENT OPD. So this was a 4 weeks duration. So the initially seen by the ENT surgeons, they did a DL scopy, and they showed a growth over the posterior part of the vocal cords. And since the child also had a cough, the child was referred to the pediatric OPD. Here we saw the X-ray was not very significant. There was a doubtful cavitatory patch here in the left upper lobe, which were confirmed with a CT. CT was definitely showing a cavitatory consolidation in the left upper lobe, and we did a tuberculosis workup. CBC was normal, MAN2 was strongly positive, ESR was elevated, sputum AFB was positive, gene expert was also positive with no rifampicin resistance. This child was also started on anti-tuberculosis therapy, and the child is currently doing well. Right. So next topic is pneumonia. Pneumonia, common infection, respiratory infection. So in older than 5 years, the etiology remains the same. Between 5 to 18 years, the etiology remains the same. And what we should know is the atypical organisms like Mycoplasma and Chlamydia are the most common etiological agents, even in an adolescent. But still, viral infections are also still common, particularly rhino, adeno, and influenza. These are 3 common viral infections that can cause pneumonia in the adolescents, viral pneumonia. There are a certain group of special population in adolescents where the etiological agents can vary. For example, in immunodeficiency or HIV, gram-negative bacilli staph aureus can be the causative organisms. Fungal infections like aspergillus and mucor can be there. Viral, again, RSV, adeno, and influenza virus can be the organisms. In cystic fibrosis, the profile is slightly different because they are more prone for infections with staph aureus, Pseudomonas, H. influenza, and Burkholderia. Rarely, non-tuberculous mycobacteria also can happen. In sickle cell anemia, the profile is almost similar. The atypical organisms are more common, and strep pneumonia and staph aureus also can cause the disease. So this is one of our cases, 13-year-old adolescents who presented with fever 11 days and cough cold 7 days and skin rash of 4 days after starting oral antibiotic elsewhere by a pediatrician. On examination, this child had a maculopapular rash over the trunk, forehead, and the limbs. On respiratory examination, the artery was diminished in the left lower zone. Initially, the diagnosis was this child was admitted with the diagnosis of viral exanthematous illness. But when we took the X-ray was showing a consolidation of the left lower lobe. The CBC was showing a falling trend in hemoglobin, and the MCHC was always high. This was the point that triggered a doubt in us. There was always high MCHC, and the peripheral smear was showing agglutinated RBCs. So now we knew that there is some sort of hemolysis going on. We did the DCT, which was positive, and then we suspected Mycoplasma, which came much later after 4 weeks. But we knew that this was a child with Mycoplasma pneumonia with hemolytic anemia. Started the child on azithromycin. This child did very well after the antibiotic course. Coming into the this problem is nowadays being increasingly seen in our setup, somatic cough. Somatic cough is a chronic non-specific cough. It is a condition typically seen in adolescents, particularly in the early adolescents, usually between 10 to 14 years. The typical characteristic is loud, repetitive, persistent cough with honking or barking quality, usually lasting for months to years. So the last patient I saw was having this cough for 4 years. So the striking finding is the Law-Bell difference. So this particular cough, even though the child has a very disturbing cough, very incessant and intrusive cough, this child will not pay much attention to the cough. That is the Law-Bell indifference. So that is a very important finding that we can notice when you are examining this child. But the hallmark finding is the disappearance of cough during sleep. That is considered to be the hallmark finding of somatic cough in adolescents. Diagnosis is usually challenging, and it is not the first diagnosis. It is always a diagnosis of exclusion. We have to rule out all the problems, including asthma, tuberculosis, allergic rhinitis, allergic conditions, all the possibilities of chronic cough before finalizing that somatic cough as the final diagnosis. And we should also search for important comorbid conditions like anxiety, depression, sometimes parenting problems, punishing parents. So, but this particular cough is not likely to settle with your pharmacological interventions, and many times the non-pharmacological interventions like suggestion therapy, hypnosis, and cognitive behavior therapy, only these things are going to work. Right. So coming to the next topic of chronic lung diseases, we know that many of the chronic lung diseases in early childhood can persist or progress into adolescent and then to early and then to adulthood also. A few of those conditions are cystic fibrosis, asthma, primary ciliary dyskinesia, bronchiectasis, interstitial lung disease, and chronic lung disease of prematurity, obliterative bronchiolitis, and neuromuscular disorders like muscular dystrophy. So what are the reasons for worsening in adolescent period? Number one is malnutrition, either undernutrition or obesity, both can cause problems. And environmental air pollution. Nowadays, the environmental air smoke levels and the particulate matter is very high, that can worsen the lung functions. And substance abuse and high risk behavior is also very common in this particular age group. And as we already discussed, the adherence to medical treatment is poor in this particular age group. And coexistent mental health conditions can also worsen the drug compliance. And there's always a overlap. Adolescents generally get confused between whether to go for pediatric care or adult care, because the treatment strategies, approaches only are different between these two groups. So how do we target this particular group and how do we approach them? Number one, we should have a dedicated adolescent health clinic, which should have a multidisciplinary team, including an adolescent physician, a pulmonologist, and a dietitian and a psychiatrist. And we should avoid triggers like smoking, alcohol, and we should advocate healthy lifestyle practices like breathing exercises, yoga, and good physical activity, and a balanced diet. And these children are more prone for infection, so the seasonal vaccinations like influenza, pneumococcal vaccination, if not given previously, those should be advocated. And for these children, there should be a strong parent school support groups which will help them in the treatment. Right, coming on to the last topic, sleep problems in adolescence. Sleep problems nowadays are becoming more common in adolescence. Why is their pattern disturbed? Because one is the environmental factors. Environmental factors, particularly this academic pressure, the schools giving academic pressure for the results and the homeworks they get, and the lack of physical activity, play activity. So these are the environmental factors that can cause sleep problems. Sleep-wake variability, because adolescents sleep differently in the weekdays, sleep differently in the weekends. So this different sleep-wake variability can lead on to circadian malalignment. And early school times, nowadays school start at 7:30 also. Further, the child has to wake up by 4:30, 5 o'clock. Because of this, but unfortunately, they sleep very late by 11 o'clock or 12 o'clock. Because of poor sleep or sleep deprivation, they get this decreased alertness and poor concentration. And excessive daytime sleepiness can also happen because of sleep deprivation. And risk-taking behavior like substance abuse, alcohol is highest in the adolescent age group, that can also cause problems. So the common sleep problems that we encounter are: number one, insomnia; number two, delayed sleep-wake phase disorder, and obstructive sleep apnea, restless leg syndrome, and narcolepsy. So how do we avoid the sleep problems? What are the recommendations for healthy sleep habits in adolescence? Number one, the adolescent should maintain an organized and a consistent sleep-wake pattern. He should set and enforce a consistent bedtime and wake time on both weekdays and weekends. The differentiation should not be more than 1 hour. The weekday and weekend schedule the difference should not be more than 1 hour. And any kinds of electronics or mobiles or screens should be avoided inside the bedroom. And the daily morning sun exposure is supposed to set right the circadian malalignment. So we should increase the daily morning sun exposure to adolescents so that it corrects the circadian rhythm. And any stimulating substances like caffeine should be avoided or eliminated from the diet. So what are the key messages? Stress, malnutrition, poor adherence to treatment, they are important factors for poor asthma control as well as TB control in adolescents. And high prevalence of TB, as I said, is mainly because of malnutrition, also because of substance abuse. Mycoplasma is a common cause of adolescent pneumonia, and somatic cough is a diagnosis of exclusion and requires behavioral therapy because pharmacological measures don't work most of the times. And sleep problems in adolescents are very common and can be overcome by healthy sleep habits. So thank you all for your patient listening.
Thank you very much, sir. With that, we wind up our session. It was such a wonderful session. All topics comprehensively covered by our star speakers. I'm very grateful to the Department of Pediatrics, Sri Ramchandra Institute. Thank you. Thanks to the department. Thanks to the speakers. Thanks to our IAP CCB OB members, our president, madam, of course, Dr. Lakshmi, our secretary, Dr. Subramaniam sir, and our treasurer, Dr. Nisha ma'am. Thanks to the EB members for their valuable support. Thanks to everybody who took their time out to attend these sessions today. I'm sure you found it very useful and productive. The video is available on YouTube in our IAP CCB channel. So whoever has missed it can always take a look. So with that, thank you very much and have a great evening. Thank you.
Thank you, ma'am.
All for joining.